Welcome to the Deep Dive. This is where we take your source material, really jump in, and pull out the most important bits of knowledge and insight just for you.
Exactly. Think of us as your guides through sometimes tricky information. We highlight what really matters so you can get up to speed on a topic, quickly.
Absolutely. And today we're plunging into something that's, well, it's woven into pretty much everything: how we think, how we interact, how the world works. We're talking about bias.
Our source for this is a pretty comprehensive Wikipedia article on bias. It gives us a great starting point, a really broad overview of all its different shapes and sizes.
So our mission here is to unpack all that. Not just define bias, but explore the sometimes surprising ways it shows up, understand what's driving it, and see its actual impact on, the decisions you make, how you see things, the information you get every day.
Yeah, get ready because bias is it's way more common and often sneakier than you might think at first glance.
So join us now as we take this journey together into the material. Our goal is to help you walk away with a much, much clearer picture of this really fundamental part of, well, being human.
Okay, so let's start unpacking. The source kicks off with the big question. What is bias exactly?
Right. At its heart, the definition it gives is like a disproportionate weight, either for or against an idea or a thing, often seen as, inaccurate, maybe closed-minded, or unfair.
And interestingly, the source points out these leanings can be pretty deep-seated, maybe even innate to some extent, or they could be things we pick up, things we learn over time from experience.
It also mentions the more technical meaning, like in science or stats, where bias is basically a systematic error, not just random mistakes and a constant tilt in one direction.
Yeah, but what's really fascinating, I think, is where the word actually comes from. The material traces bias back through Old French and Old Provençal. Apparently, it literally meant sideways or askance.
Sideways, like not straight.
Exactly, and it seems the word came into English through the game of bowls, where the balls weren't perfectly balanced. They had a weight on one side, which made them curve or go sideways.
I love that. Thinking of bias as like a built-in weight that makes things curve off course.
It's a great metaphor, isn't it? And it helps explain why the source doesn't treat bias as just one thing. Like those bowls, our leanings show up in lots of different ways, different landscapes, depending on the context.
Okay, let's start with maybe the most personal landscape. The biases inside our own heads, cognitive biases. The source describes these as predictable patterns in thinking, often missteps.
Yes, they're like recurring glitches in how we judge things. Sometimes they create what the source calls a subjective social reality that isn't quite right. They can lead to, distorted perceptions, inaccurate judgments.
But I saw the source mentions they're not always bad. Some can actually be adaptive, right? Helping us make quicker choices when speed matters more than being perfectly accurate.
Exactly. Our brains are amazing pattern finders, but sometimes those shortcuts, while they lead us astray, a lot of them are just byproducts of how our brains handle the sheer amount of information thrown at us.
So these are like our mental default settings.
Yeah.
Sometimes helpful, sometimes not. Let's look at a few key examples from the source that really illustrate this. First up, anchoring.
Right, anchoring. That's our tendency to grab onto the very first piece of information we get, the anchor, and rely on it too heavily when making decisions or estimates.
The classic example, like the source uses, is buying a used car. That initial asking price, even if it's way too high, becomes the anchor. And then any offers after that are judged against that number, often making them seem more reasonable than they actually are. It just pulls your judgment towards it.
It really shows how that starting point can totally warp the final decision. Okay, building on that pattern finding thing, another really interesting one the source brings up is apophenia, sometimes called patternicity.
Oh, is that like seeing shapes in clouds? Or the man in the moon? I think the source called that specific visual type pareidolia.
Yes, exactly. It's our tendency to see meaningful patterns or connections in just random stuff. The source gives examples like gamblers thinking they see patterns in lottery numbers or roulette spins, even though each one is totally random.
Right.
Our brains just desperately want to find order, so sometimes they just invent it.
That feels kind of related to how we explain why things happen. There's attribution bias, where we make mistakes figuring out why someone did something, including ourselves.
Right. We're definitely not objective there. The source notes a common pattern. We tend to explain other people's actions based on their personality. Oh, they cut me off because they're a jerk. But when we do the same thing, we blame the situation. I had to swerve. The traffic was insane. That's often called the actor-observer difference.
They're just lazy, but I had a really bad day. Yeah, got it. Now, confirmation bias. Wow, that feels incredibly relevant right now.
It really is. The source describes it as actively looking for, interpreting, and remembering information that confirms what you already believe,
Right.
while at the same time downplaying or just ignoring anything that contradicts it.
It's like having this internal filter, or like the source suggests, an internal yes man just nodding along with your existing thoughts.
And the source really stresses that it's stronger for things we feel emotional about or beliefs we hold really deeply, which helps explain how people can see the exact same information and somehow become even more convinced they're right, even if they disagree with each other.
Yeah.
It fuels overconfidence, makes beliefs really sticky, resistant to change, even when new evidence comes along.
That seems connected to framing, too, the idea that how information is presented changes how we see it.
Absolutely. The source calls framing a schema of interpretation, basically the lens we use to make sense of something. It points out how media or leaders can frame facts to imply a certain problem exists and hint at a specific solution, often one that fits a political agenda. It's about shaping the context around the facts.
Like putting a specific kind of frame around a picture to change how you feel about what's inside it.
Exactly. And speaking of impressions, the halo effect and the horn effect show how our overall feeling about someone or something, positive or negative, can color our judgment about their specific qualities.
So the halo effect is the positive one, like a saint's halo. If you generally like someone or a brand, you're more likely to think their individual traits or products are good too. The source mentions this happens a lot with, like, physical attractiveness or brand image.
And the horn effect is just the opposite the devil's horns. A bad overall impression makes you quicker to judge specific details negatively, even if they're not objectively bad.
Makes sense. And the self-serving bias sounds, well, pretty much like what it says on the tin. A bias that serves yourself.
It is. It's twisting our perceptions to keep our self-esteem up. So we credit our successes to ourselves. I nailed that presentation because I'm brilliant. But blame failures on outside stuff. The audience just wasn't receptive. The source notes this pops up everywhere. Work, relationships, sports, even when we're shopping.
Okay, and finally, among these common cognitive patterns, there's the status quo bias.
This is just a preference for things staying the way they are. Any change, even if it might be better, feels like a loss compared to the current situation, the baseline.
So you just stick with the familiar option, even if a new one might be objectively superior, just because changing feels risky or like giving something up?
Exactly. The source highlights evidence showing this really does affect decisions often, making people hesitant to switch even when better alternatives are right there.
Wow, okay, that's a lot. Just about how our own minds can lead us down biased paths. As you hear these, maybe pause and think. Which of these mental shortcuts or tendencies might be playing out in your own day-to-day thinking and how you see things?
Now, bias isn't only about our internal thought processes. It also crops up when different interests clash. Which brings us to conflicts of interest, another area the source covers.
Right, a conflict of interest happens when someone has competing interests, maybe a personal financial stake, that could potentially sway their professional judgment away from their main responsibility, like to the public or their employer.
And the crucial point the source makes here is that it's the potential for that undue influence that creates the conflict. It doesn't necessarily mean something improper has happened, just that the situation creates that risk, that vulnerability.
The examples here really show how outside pressures can introduce bias. Corruption is an obvious one. Bribes, kickbacks, trying to influence outcomes illegally.
Favoritism is related, often called in-group bias. That's preferring people from your own group over others. The source mentions cronyism favoring friends and nepotism favoring family, often in things like hiring.
Lobbying is another place where this potential conflict pops up, trying to influence politicians or decision makers. The conflict arises if someone whose job is to serve the public good might personally gain by pushing policies that benefit the private interests they represent.
And regulatory issues offer a clear picture too. Self-regulation, where an industry polices itself, can be biased if the priority becomes looking good rather than actually fixing problems. And then there's regulatory capture. That's where the agency meant to regulate an industry ends up kind of serving the interests of that industry instead of the public.
Why does that happen? The source suggests it's partly because the industries being regulated have a lot at stake and pour resources into influencing the agencies, while the general public, where each person's stake is smaller, doesn't pay as close attention. It's an uneven fight for influence.
And shilling, that's another form. where someone secretly promotes something but pretends to be independent, like paid product reviews that don't say they're paid, the source notes that can even be illegal sometimes. These examples really highlight how competing interests can inject bias into decisions within big systems.
Thinking about these conflicts of interest, where do you see the potential for this kind of bias maybe affecting things in the world around you, in business or politics or other fields?
Okay, moving from conflicts influencing decisions, let's look at bias within the information itself. Starting with statistical biases, which the source gets into.
So this is about a systematic tendency in how data is gathered, analyzed, or interpreted that leads to results that are, well, misleading. It's not just random error. It's a consistent skew.
Yeah, it can creep in through how you pick your subjects, that's selection bias, or how you collect the data, like with reporting bias or the observer expectancy effect. For instance, selection bias happens if the group you study isn't really typical of the larger population you want to understand.
And reporting bias or social desirability bias, that's interesting. It's when people, say in surveys, don't report things accurately. Maybe they over-report good behaviors and under-report things seen negatively.
Right. Which makes it really tough to get honest answers on sensitive topics from surveys alone. And the observer expectancy effect is another tricky one, where what the researcher expects to find can subtly influence how participants behave or even how the data gets recorded. That's why we have things like double-blind studies, to try and minimize that.
So statistical biases are really about skewing the data itself, or how we gather it, which then messes up the conclusions we draw from it. How does knowing about these biases make you think differently about the stats and data you see in the news or in research findings?
Okay, now let's shift focus to bias aimed specifically at people prejudices. The source defines prejudice as basically prejudgment, often an unfavorable one, usually based on group membership, things like gender, race, age, social class, and so on.
Yeah, the source notes that bias and prejudice are generally seen as very closely linked, almost like different sides of the same coin leaning unfairly for or against something or someone.
There's that quote the source mentioned, something about people thinking they're thinking when really they're just rearranging their prejudices. It really speaks to how deep these prejudgments can run.
The source lists specific examples here, like ageism, classism, lookism, judging based on appearance, and racism.
It also includes sexism. The source defines this as prejudice or discrimination based on sex or gender, noting it primarily affects women and girls. It links it to stereotypes, traditional roles, and sometimes a belief in the superiority of one's sex. Reporting source definition neutrally.
These examples really drive home how bias can turn into harmful assumptions about entire groups. Thinking about this, how might these kinds of prejudgments, maybe even unconscious ones, based on these characteristics, subtly affect everyday interactions or opportunities?
The source then broadens out again to look at contextual biases. This is about how bias actually shows up and works within specific fields or institutions. It often combines elements of the other types we've discussed, cognitive, conflict-based, etc.
Right. Like in academia, it mentions claims of academic bias, political or religious leanings influencing work. There's experimenter bias, which we touched on. Funding bias research results may be leaning towards the sponsor's interests. And publication bias, the tendency for studies with significant or positive findings to get published more easily.
In law enforcement, the source lists examples like driving while black and racial profiling, and also victim blaming. These suggest bias potentially influencing encounters and how situations are interpreted within the justice system.
Media bias is a big one it covers. The source mentions this involves choosing which stories to run and how they're covered. It notes this can be influenced by factors like media ownership, the target audience, advertisers, and so on, presenting source points neutrally.
And related concepts in media include agenda setting, making certain issues seem more important just by covering them a lot, and gatekeeping, which is essentially filtering what information gets out to the public. Sensationalism, hyping things up, is also mentioned.
The source touches on other areas too, like educational bias in textbooks or maybe from teachers, inductive bias in machine learning, the assumptions built into algorithms, insider trading, and match fixing in sports.
Yeah, these examples really hammer home that bias isn't just in our heads. It can be baked into the systems, the institutions, the information channels we deal with every day. Thinking about the news you follow, the places you work or study, even online communities where do you maybe recognize these contextual biases playing out.
And then finally, the source delves into something really crucial: implicit bias. sometimes called an implicit stereotype.
Yeah, this is key because it's about the unconscious associations we make, attributing certain qualities to members of different social groups.
It gets shaped by our experiences, by the associations we absorb from society, often without even realizing it, related to things like race, gender, age.
And the really critical point here is that it's unconscious. These biases can shape our perceptions, our judgments, even our actions automatically and unintentionally, even if consciously we hold totally different beliefs. It's part of what's called implicit social cognition, those automatic mental processes for dealing with social information.
The source notes this concept is well established in psychology, highlighting just how significant this subtle, below-the-radar influence can be.
So, wow. We've journeyed through a really wide landscape of bias, haven't we? From the subtle, unconscious ways our minds work and the shortcuts they take, to patterns in data, to conflicts driven by competing interest, to those deeply held prejudices, and finally, how bias shows up in specific contexts, institutions, and even implicitly.
It really does show just how complex bias is and how pervasive. It's often hidden, sometimes we don't even mean it, and it truly affects how everyone sees things and makes decisions, whether we know it or not.
Our whole mission with this deep dive was really to help you navigate that complexity, to pull out the key ideas and connections from the source material, giving you a clear handle on this, well, really critical topic.
We've seen its origins, its many different faces, cognitive, statistical, conflicts of interest, prejudice, contextual, implicit, and how it touches everything from data analysis to judging others to the information we consume.
So, to leave you with a final thought to chew on, considering the sheer number and all the different kinds of bias we've just talked about, which type do you think is most likely to be influencing you, perhaps in ways you don't consciously realize? And what might it actually take personally, maybe even collectively, to really start pushing back against its effects?
Lack of movement, unconsciousness, and blunting that stress response.
Yeah.
And the history here is quite interesting because early anesthetics, things like ether, they were pretty good at knocking you out and maybe paralyzing you, but they didn't really blunt that physiological stress response.
Yeah.
The material highlights Harvey Cushing's work, realizing that managing the body's reaction to the trauma of surgery was just as crucial as stopping the pain itself. This realization, essentially adding stress response blunting to the list of goals, led to significantly lower mortality rates eventually.
That's a huge insight. It's not just about putting you to sleep. It's about protecting your body from the insult of the surgery.
Exactly. The inhaled anesthetics used in general anesthesia affect different parts of the nervous system, your spinal cord for preventing movement, and your brain for the sedation, hypnosis, and amnesia effects.
Okay.
And here's a cool little fact. The potency of these inhaled drugs actually correlates pretty well with how well they dissolve in oil.
Really? Why?
Well, it suggests they work by binding within fatty, sort of oily protein cavities in nerve cell membranes.
Huh, interesting.
And that potency is quantified by something called MAC, or minimum alveolar concentration.
Right.
It's the percentage of the anesthetic gas in your lungs that prevents 50% of people from moving in response to a painful stimulus. It's a standardized way to measure anesthetic strength, which is obviously a critical step for safety and consistency.
And practice has changed too, hasn't it? Since the 1930s, it shifted from relying solely on these inhaled agents.
That's right. They moved towards using a combination of intravenous or IV drugs along with the inhaled drugs. This combo approach significantly improved the risk profile and also the speed of recovery. The material points out it actually lowered the odds of dying in the first week after anesthesia.
Wow. So it's more like a cocktail now, designed for specific effects.
Pretty much. You might get, say, propofol via IV to quickly induce that hypnotic state, maybe fentanyl for powerful pain release and stress blunting, midazolam for amnesia, and then maintain unconsciousness with an inhaled agent like sevoflurane.
Okay.
Although the material does know that with some of the newer IV drugs, you can even do total IV anesthesia or TIVA without any inhaled agents at all now.
And the equipment has kept pace, I assume?
Oh, absolutely. The anesthetic machine manages the inhaled gases very precisely, while IV pumps deliver measured drug infusions. Modern machines have layers and layers of fail-safe systems built in. Very sophisticated stuff.
Okay. Let's shift to sedation, or twilight anesthesia.
Right. So the state created here is more hypnotic. It reduces anxiety, so it's anxiolytic, causes amnesia, and provides some muscle relaxation, but it's centrally produced. The patient generally looks sleepy and relaxed.
Maybe still responsive.
Often, yes. They can often still interact if prompted, even if they won't remember it later.
And this is used for procedures that are, like, unpleasant but don't need total unresponsiveness.
Exactly. Things like colonoscopies, maybe some dental work, drugs like benzodiazepines, propofol, or sometimes ketamine might be used. But a key point the material makes is that sedatives alone often don't provide much actual pain relief.
Okay.
So they're usually combined with analgesics, with pain relievers.
And a major advantage compared to general anesthesia.
Well, generally it avoids the need for airway support, like breathing tubes or mechanical ventilation. And it tends to have less impact on the cardiovascular system, which can make it a safer option for certain patients, particularly those with heart or lung issues.
Makes sense. Okay, then there's regional anesthesia, blocking pain from just a specific body part?
Right. This uses local anesthetics. We already touched on simple local infiltration, just numbing a small spot.
Like for stitches?
Exactly. And peripheral nerve blocks, which numb a larger area supplied by a specific nerve or group of nerves.
Right.
Intravenous regional anesthesia, that beer block we mentioned.
With the tourniquet?
Yep. Injecting dilute local anesthetic into a limb vein after putting on a tourniquet high up on the limb to keep the drug contained there. Then there are central nerve blocks around the spinal cord. Topical anesthesia for surfaces, tumescent, which is large volume dilute stuff used for things like liposuction, and even systemic use, like using these drugs orally or IV for certain chronic pain conditions like neuropathic pain.
Is there evidence this helps beyond the immediate procedure, like with long-term pain?
Well, the material mentions a Cochrane review finding some moderate evidence that regional anesthesia, specifically things like epidurals or nerve blocks, might help reduce persistent postoperative pain after certain surgeries.
Okay.
Like thoracotomy, which is chest surgery, or cesarean section. Low evidence after breast cancer surgery. It's an area of ongoing research, but the potential to impact that transition from acute to chronic pain is definitely significant.
And for those peripheral nerve blocks, specifically injecting around larger nerves?
Yeah. The material highlights that using ultrasound guidance, sometimes combined with electrical nerve stimulation, is now really the preferred technique.
Why is that?
It helps the provider place the anesthetic much more accurately. This generally leads to a better, more reliable block, less need for extra pain medication later, and fewer complications like nerve injury or hitting a blood vessel. And you can even use continuous infusions through a tiny catheter placed alongside the nerve after major surgery, like knee or hip or shoulder replacements. This can potentially lower complications further and provide really excellent post-op pain control compared to just relying on IV opioids, for instance.
And safer than central blocks, generally.
The material notes they generally carry a lower risk of serious neurologic complications compared to the central blocks around the spine, yes.
Which brings us neatly to central neuraxial blockade, spinal, epidural, and caudal.
Right. These techniques involve injecting anesthetic near the spinal cord to provide pain relief and sometimes muscle relaxation for procedures on the abdomen, pelvis, or lower extremities.
What's the difference between a spinal and an epidural?
Okay, so a spinal block is a single injection directly into the subarachnoid space. That's the fluid-filled space right around the spinal cord. It works very quickly, gives a very profound sensory block, and usually affects muscles quite a bit too. Uses a small dose.
Okay, an epidural.
An epidural block is injected into the epidural space, which is just outside that subarachnoid space membrane. It typically uses larger volumes of anesthetic and often involves placing a thin catheter.
Ah, so you can give more later.
Exactly. It allows the provider to give more drug later, either as additional injections or a continuous infusion to extend the effect for hours or even days. Epidurals usually provide good pain relief without affecting muscle control as much as spinals tend to do.
And caudal.
A caudal block is basically similar to an epidural, but it's injected way down at the very tail end of the spinal canal, in the sacrum, often used in pediatrics.
Physiologically, what do these central blocks do besides block pain?
Well, a major effect is causing significant dilation of blood vessels, both arteries and veins, since about 75% of your blood volume is normally sitting in your veins.
Right.
This venous dilation is a major factor leading to the common drop in blood pressure you often see with these blocks.
Doesn't matter where the block is.
Yes, the effect is much greater the higher up the block is placed, especially if it gets above the 5th thoracic vertebra level in your chest.
And here's an interesting little insight from the material. Sometimes a block might seem ineffective, but it's not necessarily a technical failure of the injection itself. It can actually be because the patient isn't adequately sedated or is experiencing really high anxiety.
Ah, so their psychological state can influence how they perceive the pain signals the block is trying to stop.
Exactly. It kind of overrides it.
That ties nicely into the broader topic of acute pain management, which obviously extends beyond just the operating room itself.
Yeah. Pain isn't static, is it? Persistent, painful stimuli can actually sensitize your nervous system.
That's right, making pain harder to control down the line and potentially even leading to chronic pain developing.
Which makes preemptive pain management so important, trying to block those pain signals before they even fully register.
Right, potentially reducing both the immediate postoperative pain and the risk of developing chronic pain later on. And this should always be tailored to the specific surgery, the setting, and the individual patient, of course.
How is pain managed after surgery, typically?
Well, it can be on demand, like giving opioids or NSAIDs when needed, or using patient-controlled analgesia, PCA.
Where you push the button yourself?
Yeah, exactly. The patient can push a button to give themselves a small, pre-programmed dose within safe limits. The material notes PCA often results in slightly better pain control and higher patient satisfaction.
Okay.
And then there were those preemptive approaches we talked about, like using epidural catheters or peripheral nerve blocks placed before or during surgery to provide ongoing relief.
Is there strong evidence for those preemptive methods?
Yes, the material gives a powerful example, using epidural blockade after major abdominal aortic surgery. It doesn't just provide much better pain relief, especially when the patient moves.
Right.
But it also significantly cuts down the time patients need breathing tubes post-op, roughly halving the duration of tracheal intubation. And it reduces complications like prolonged ventilation and even heart attacks.
Wow. So good pain control isn't just about comfort. It's crucial for overall recovery.
Absolutely critical.
Okay. But like any medical intervention, anesthesia does come with risks and complications.
Of course. These can result in morbidity, which is disease or disorder, or, very rarely, mortality, meaning death. But it's often challenging to pinpoint if a bad outcome is solely due to the anesthesia itself versus the patient's underlying health problems or the complexity of the surgery they're having.
That statistic you mentioned earlier from the material was really striking. It broke down the likelihood of death based on the primary cause.
Yeah, it showed that deaths totally attributed to the patient's underlying health issues, like 1 in 870, are vastly more common than deaths attributed just to surgical factors, maybe 1 in 2860, which are in turn vastly more common than deaths solely attributed to the anesthesia itself, which was incredibly rare, something like 1 in 185,000.
So it makes it crystal clear that the patient's baseline health is the single greatest factor influencing their overall anesthetic risk.
Absolutely. That's probably the most crucial takeaway for anyone facing a procedure. While anesthesia is incredibly safe today compared to the past.
Much safer.
Way safer. But the risks are additive, and the individual's own health profile really dominates that risk equation.
Yep.
The material does compare modern safety to a study from 1954, highlighting huge improvements over the decades, even acknowledging it's hard to make perfect comparisons across time and countries.
Does the material list specific risk factors for a bad outcome, considering the procedure and the anesthetic together?
Yes, it does. Things like having a higher ASA physical status score. Remember, ASA 3, 4, or 5 that dramatically increases your risk over 10 times higher than an ASA 1 or 2 patient. Being older, especially over 80, increases risk significantly. Emergency procedures are much riskier, about 4.4 times higher risk than planned ones. Even the experience level of the provider plays a small role, apparently.
Interesting. And type of anesthetic?
Generally, regional anesthetics carry lower risk than general anesthesia.
And certain patient populations are just inherently higher risk.
Yes, like obstetrical patients managing mother and baby simultaneously adds complexity. Also, the very young, infants, and the very old, frail, elderly patients all require particularly careful planning and management.
There was also a mention of a FDA warning from 2016 related to anesthesia exposure in young children and pregnant women.
Yes, that's right. The warning stated that repeated or lengthy exposure to general anesthetic or sedation drugs in children younger than 3 years old or in pregnant women during their 3rd trimester may affect brain development.
And that generated some controversy.
It did, quite a bit. The material notes the different viewpoints. For instance, the American College of Obstetricians and Gynecologists criticized the warning, pointing to a lack of direct, high-quality human evidence and worrying that it might scare people away from medically necessary procedures for themselves or their children.
Understandable concern.
On the other hand, advocates for the warning argue that conducting a randomized trial where you deliberately expose young children to potentially harmful agents would be completely unethical.
Right.
They point to concerning findings in animal models that show potential mechanisms for brain injury, and also to some human observational studies suggesting an increased risk of learning disabilities. The material cited one study showing more than double the risk associated with multiple anesthetic exposures in very young children.
So it's a really complex situation where you have medical necessity potentially colliding with limited human data and very real ethical considerations.
Exactly. It's a difficult balance.
Oh, okay. Moving past the procedure itself, the journey through anesthesia includes recovery.
Right, the emergence phase.
The immediate period right after the anesthetic is stopped is called emergence. And this is still a critical time, isn't it? Careful monitoring is still needed because the risks don't just vanish instantly.
Absolutely not. Common issues during emergence include things like nausea and vomiting, happens in about 10% of patients apparently. Needing temporary airway support is also fairly common, almost 7%.
Okay.
Urinary retention, especially in older adults. Hypotension, a drop in blood pressure. And hypothermia, shivering, and confusion are also pretty common, often related to the body's systems kind of rebooting after being suppressed and maybe not generating heat or moving much during the surgery.
Is there anything else less common mentioned?
A rare but notable issue mentioned is functional neurological symptom disorder, which can sometimes manifest after anesthesia. And a more frequently discussed topic is postoperative cognitive dysfunction, or POCD.
POCD, right. This is basically a disturbance in thinking that can occur after surgery.
Exactly. It includes that immediate emergence delirium, the acute confusion right as you wake up, and also early cognitive dysfunction, which is sort of diminished function noticeable in the first week or so.
Does one predict the other?
Interestingly, the material notes that while delirium right after surgery does predict that early dysfunction the first week, neither of those seems to strongly predict the development of long-term POCD.
And there was that insight from a UCLA study mentioned.
Ah, yes, that was fascinating. It suggested that brain recovery isn't just the anesthetic drug passively leaving your system, like evaporation. It's actually an active process. The brain is essentially rebooting itself, going through complex sequences of activity states to regain consciousness and normal function.
That makes so much sense. It's an active repair or reset process.
Exactly.
And long-term POCD is that more subtle decline that can persist for weeks, months, or maybe even longer.
That's the one. The material describes how relatives might notice issues like lack of attention, memory problems, maybe a loss of interest in things. People in the workforce might find they just can't complete tasks as efficiently or accurately as they could before the surgery.
Is it common? And what causes it?
Well, it's pretty well established after procedures like cardiac surgery, where tiny particles in the bloodstream called microemboli, generated during the heart-lung bypass, are thought to be a main cause.
Okay.
But it also definitely occurs after major non-cardiac surgery, too.
Yeah.
The causes there are less clear, could be inflammation, stress response, maybe subtle effects of the anesthetic itself, but older age is consistently identified as a significant risk factor.
Okay. Stepping back now, it's really remarkable to trace the rich history of this field. This isn't exactly a new concept, is it?
Not at all. The material takes us way, way back to prehistory with herbal remedies. Things like alcohol and opium poppies were used thousands of years ago in Mesopotamia.
Wow.
Ancient Egyptians apparently used crude sedatives, possibly from plants like mandrake.
And in Asia?
Well, there are accounts, maybe legendary, of Bianchi using general anesthesia in ancient China around 300 BCE. But a more verifiable figure is Huatuo in the 2nd–3rd century CE. He developed his Mafutsu-san mixture, containing things like Korean morning glory. While the exact recipe is lost, his general approach was famously used by a Japanese surgeon named Hanaoka Seishu in 1804 for successful surgery under general anesthesia, apparently the first documented case.
But it didn't spread quickly.
No, knowledge spread pretty slowly, partly due to Japan's relative isolation until the mid-1800s.
What about Europe and the Americas?
Well, various plants containing tropane alkaloids like belladonna or henbane were used. Medieval times saw things like the soporific sponge.
The soporific sponge, what was that?
It was apparently soaked in a mixture of things like opium, mandragora, hemlock. It was dried and then later moistened and held under the patient's nose so they'd inhale the fumes. The material says it was widely recommended for a time, but then kind of abruptly discarded.
Weird. And local anesthesia has its own separate history.
Totally separate trajectory initially. Inca shamans in South America would apparently chew coca leaves and then spit into wounds to numb them.
Right, coca leaves.
Cocaine, isolated much later from coca leaves, became the first truly effective local anesthetic. It was famously used in eye surgery in 1884 after Sigmund Freud suggested it to his colleague Karl Kahler.
Or Freud.
And the idea of central nerve blocks injecting around the spine came even later. August Beer used cocaine intrathecally right into the spinal fluid in 1898. And Nikolai Rakovichin out of Pitești used opioids intrathecally just a few years later in 1901.
So the push towards modern Western general anesthesia often focuses on ether and nitrous oxide, right?
That's the classic story, yes.
Yeah.
Ether might have been synthesized way back in the 8th century, but its effects weren't seriously explored medically until much, much later. By the early 1800s, it was mostly used recreationally at ether frolics.
Ether frolics. Sounds dangerous.
Probably was. And nitrous oxide, discovered by Joseph Priestley in 1772, was initially seen as maybe dangerous too. It was Humphrey Davy in 1799 who famously experimented on himself.
Laughing gas.
Exactly. Found it made him laugh, hence laughing gas. He actually noted its anesthetic potential way back in 1800, but for some reason, that wasn't immediately pursued for surgical use.
So who gets the credit for starting modern Western anesthesia?
Well, it's often attributed to Crawford Long, a physician in Georgia, U.S. He noticed people at those ether frolics didn't feel pain when they fell or injured themselves. He used ether for surgery in March 1842, but didn't publish his findings until 1849.
So he was first, but didn't tell anyone right away.
Pretty much. The public demonstrations were really crucial for getting widespread buy-in. Horace Wells, a dentist, had a famously failed public demo with nitrous oxide in Boston in 1845, which unfortunately set things back a bit.
Ouch.
But then William Thomas Green Morton, another Boston dentist, had a very successful public demonstration using diethyl ether at Massachusetts General Hospital in October 1846. That was the famous event under the ether dome.
Right, the gentleman, this is no humbug moment.
Exactly. The surgeon John Collins Warren was convinced. And Oliver Wendell Holmes Sr., the physician and writer, coined the terms anesthesia and anesthetic soon after that event.
Did Morton try to keep ether secret?
He did. He tried to patent it under the name lithium, disguising what it was. But the news traveled incredibly fast anyway. It was quickly adopted by surgeons in Europe and around the world within months.
But ether had problems.
Yes, it caused significant nausea and vomiting, and it was highly flammable, which is obviously a big issue in an operating room with cautery or gas lights back then. This led people to search for alternatives pretty quickly.
Enter chloroform.
Enter chloroform. Discovered independently in the 1830s, its anesthetic qualities on animals were shown by Robert Mortimer Glover in 1842.
And who popularized it for humans?
That was James Young Simpson, an obstetrician in Scotland. He demonstrated it on humans in 1847 and really championed its use, especially in childbirth.
Didn't Queen Victoria use it?
She did. John Snow administered chloroform to Queen Victoria during the birth of Prince Leopold in 1853. She apparently found it delightful beyond measure, which gave it huge royal approval.
But chloroform had its own dark side, right?
Absolutely. The first fatality occurred very quickly in January 1848, and many subsequent deaths happened due to its potent effects on the heart and breathing, especially when administered by untrained individuals.
Which highlighted the need for a dedicated specialist.
Precisely. This tragic reality underscored the critical need for a dedicated, trained anesthetist, someone whose sole focus was administering the anesthetic safely and monitoring the patient, not trying to watch the surgery or do other things.
Who filled those roles initially?
Well, initially it was often medical students, sometimes members of the public, even dentists. But increasingly, nurses stepped into this role. Professional training specifically for nurses in anesthesia was developing by the time of the U.S. Civil War.
And the material highlights Alice McGaw.
Yes, Alice McGaw, often called the mother of anesthesia. She was a nurse anesthetist working for the famous Mayo brothers at the Mayo Clinic. She kept meticulous records.
That's key.
Absolutely. Her published work detailed her experience with over 14,000 anesthetics she personally administered, without a single anesthetic-related death attributable to her technique. Her outcomes were truly remarkable for the time and really solidified the role of nurse anesthesia as a safe and highly effective practice.
Amazing. When did the first textbook appear?
The first really comprehensive textbook, simply titled Anesthesia, was published in 1914 by an anesthesiologist, Dr. James Taylor Gwathmey, and a chemist, Dr. Charles Baskerville. It became a standard reference for decades.
It's fascinating to see how far things have come. Of those early famous agents,
Only nitrous oxide is still widely used today. Chloroform and ether were replaced by much safer, less toxic, non-flammable modern general anesthetics. And cocaine, as a local anesthetic, was replaced by safer synthetic agents like lidocaine and others.
that journey from ancient herbal concoctions and soporific sponges to today's highly controlled, monitored practice is just incredible.
It really is. Decades and centuries of discovery, refinement, and thankfully, increasing safety.
It really makes you appreciate the layers involved. And that brings us nicely to the society and culture aspect, the people who actually provide this care now.
Right. Anesthetic drugs are used by various healthcare providers, but there are definitely specialized roles in medicine, nursing, and also dentistry.
So the doctors specializing in this are called anesthesiologists in the U.S.
Or anesthetists, sometimes anesthesiologists, in places like the UK, Australia, New Zealand, Japan, where anesthesia is administered solely by doctors.
The nurse anesthetists play a huge role globally, don't they?
Immense role. They administer anesthesia in 109 nations, according to the material. In the U.S. specifically, the breakdown is interesting. About a third of anesthetics are delivered by physicians working solo. Over half, about 55%, are provided by anesthesia care teams, where an anesthesiologist supervises or directs certified registered nurse anesthetists, CRNAs or anesthesiologist assistants, AAs, and about 10% are delivered by CRNAs practicing solo, particularly in rural or underserved areas.
And there are other assistant roles, too.
Yes, the anesthesiologist assistants, AAs in the U.S., and physician's assistants at anesthesia, or PAs in the U.K., who work under the direction of anesthesiologists to assist in delivering care.
Okay. And finally, the material briefly touches on special populations.
Just acknowledging that anesthesia techniques really have to be significantly altered and adapted for specific situations. It's not one size fits all.
So adapting based on the procedure.
Yes, things like cardiac surgery or neurosurgery have very specific anesthetic requirements.
And adapting based on the patient.
Absolutely. Pediatric anesthesia for infants and children, geriatric anesthesia for the elderly, bariatric anesthesia for patients with obesity, obstetrical anesthesia for pregnant patients. Each presents unique physiological challenges and needs tailored approaches.
And special circumstances.
Right. Things like anesthesia for major trauma patients in the pre-hospital environment, like air ambulances during robotic surgery, or even in extreme environments like military field hospitals or high altitude, all require unique considerations and expertise. It just underscores again that modern anesthesia is a highly specialized and adaptable field.
Right. So we've covered a huge amount of ground today, haven't we?
We certainly have.
We defined anesthesia, looked at its specific goals within the body, explored the techniques and the crucial role of the team involved, delved into the different types from general to sedation to regional blocks, discussed managing pain beyond the immediate procedure,
Looked at the risks.
examined the inherent risks and the factors influencing them, particularly patient health, navigated the complexities of recovery, including that fascinating idea of brain rebooting,
Right.
traced the rich, sometimes wild history from ancient times to modern practice.
And touched on the different professional roles of the people who provide this essential care today.
Yeah. It's clear that what might seem like a simple process from the outside, just going to sleep for surgery, is actually an incredibly sophisticated, multi-layered, team-based practice that has evolved dramatically over centuries.
Couldn't agree more.
We saw the incredible improvements in safety over time, which is reassuring, while also gaining that crucial understanding that the patient's own health is the biggest single driver of risk.
Yeah, that's key. And we touched on that fascinating idea of the brain actively rebooting during recovery rather than just passively waiting for drugs to wear off.
Which brings us to a final provocative thought for you, our listener, to ponder based on everything we've discussed today. Given that we learned a patient's underlying health is the biggest factor in anesthetic risk, and that recovery involves the brain essentially undertaking this complex rebooting process, how might actively preparing your body and your mind before a procedure, things like optimizing your health as much as possible, managing stress, maybe even just understanding the process better, how might that play a role? Not just in reducing the immediate risk of the anesthetic itself, but potentially in influencing the quality and maybe even the speed of your post-operative cognitive and physical recovery.
That's a really interesting question. Something definitely worth thinking about as you reflect on this deep dive. Welcome to the Deep Dive. Today we're plunging into the life and legacy of a name absolutely synonymous with exploring the underwater world, Jacques Cousteau.
That's right, a huge figure, and we're tackling this using a pretty comprehensive source, basically a detailed biography that hits the key moments, the innovations, and the real impact he had.
Yeah, and our mission here really is to distill that, to pull out the most important insights from all this information and give you a clear picture of who he was, what he actually did, and maybe most importantly, why he still matters today.
Absolutely. Get ready, because it's a life that was, well, way more than just looking at fish. It's packed with invention, groundbreaking filmmaking, and this growing, really powerful passion for protecting the oceans.
So let's dive in. Start at the beginning. Born June 11, 1910 in France, Jacques Cousteau.
His path wasn't always underwater, was it?
No, not at all. He actually started out in the French Navy, entered the École Navale, the Naval Academy, back in 1930.
And graduated as a gunnery officer, the source says. Seems like a standard naval career path. It did. He was even planning on going into naval aviation. But then, something really pivotal happened.
The accident.
Exactly. A really serious car crash broke both his arms. And yeah, that put an immediate stop to any flying career. But interestingly, instead of being just a setback, it kind of rerouted him, steered him towards this passion he already had for the ocean.
So it was a forced change of direction, but one that ultimately defined his life.
Pretty much. And his first steps into that world were, pretty basic. The source mentions experiments around 1936 in Toulon. It started simple. A friend lent him some Fernez underwater goggles.
Just goggles.
Yeah.
And that sparked something.
It seems so. That fascination just grew. And the early 1940s, that was a really key time for him getting properly under the surface. He started working closely with friends Philippe Tellier and Frédéric Dumas.
Right, the famous trio.
Yeah, and they were already trying to film underwater, even without breathing gear. Think about that.
That's incredible.
The source mentions a film, Par 18 mètres de fond, 18 meters deep from 1942. They used a waterproof camera case they'd rigged up. It just shows that drive, that early need to capture what they were seeing, even with massive technical hurdles.
Which makes what happened next even more amazing. Because it was during World War II, of all times.
Yeah, unlikely circumstances.
In 1943, the Cousteau, working with an engineer, Émile Gagnon, they developed and tested the first prototype of the aqualung.
And this was the game changer. I mean, there was earlier diving equipment, sure, but the breakthrough here was adding a demand regulator.
Okay, what does that mean, practically?
It means the device only gives you air when you inhale. Before that, compressed air systems often just flowed constantly, which, wasted a ton of air and really limited your dive time.
Got it. So this made dives much longer, much more efficient.
Exactly. Suddenly, extended, untethered exploration was actually possible. This invention basically created modern scuba diving as we know it, open-circuit scuba.
It just fundamentally changed how humans could interact with the sea, opened up this whole hidden world.
Completely. Now, the source also touches on something more personal from this time, a bit complex. His brother, Pierre-Antoine Cousteau.
Ah, yes, his involvement during the war.
Right. He was involved with a collaborationist newspaper. The source notes he got a death sentence after the war, though it was commuted to life imprisonment. And Jacques apparently kept his distance during that period.
A difficult family situation against a very fraught backdrop.
Definitely. And we also see his own family life taking shape. He married Simone Melchior in 1937. Interestingly, the source says he called her his business partner.
Which really says something about their relationship and how involved she was.
It does. And they had two sons, Jean-Michel and Philippe, who, as many people know, became key parts of his future expeditions.
Right. And later in life, after Simone passed away in 1990, the source mentions he married Francine Triplet in 91. He already had two younger children with her, Diane and Pierre-Yves.
So, moving past the war years, Cousteau didn't leave the Navy immediately. He actually helped them establish the Underwater Research Group, GRS, or later GERS.
Putting that new aqualung tech to work.
Pretty much. A serious effort to use diving for military and scientific goals, but it wasn't without risk.
Oh.
Well, the source mentions a tragedy in 1947. Chief Petty Officer Maurice Fargues died trying to set a depth record 120 meters using an aqualung.
Wow, 120 meters. That's deep for scuba, especially then. A stark reminder of the dangers.
Absolutely. It was still very experimental territory. But they were pushing scientific boundaries, too. In 1948, using a ship called the Elie Monnier, Cousteau's team did something really pioneering.
What was that?
Underwater archaeology. They explored a Roman shipwreck off Mahdia in Tunisia, and they did it using the autonomous diving techniques the aqualung allowed.
So the first real scientific underwater archaeology using scuba.
That's what the source suggests, yeah. A huge step, showing the practical science applications beyond just looking around or military stuff. They also helped rescue Professor Jacques Picard's bathyscaphe, the FNRS-2.
A bathyscaphe.
Yeah.
That's like a mini submarine for really deep dives,
And
right?
essentially, yes, designed for depths way beyond scuba. Their help led to the French Navy using its main sphere for the next version, the FNRS-3. So it connects Cousteau to that cutting edge of deep-sea vehicle work, too.
Fascinating. And people started hearing about these adventures.
They did, through early books. The Silent World, which he co-wrote with Dumas, was a big one. And Taillet wrote Plongée sans Cobe. These really started building his public profile.
And then he made the leap, left the Navy in 49.
Yep, ready to go his own way. And in 1950, the really crucial piece falls into place. The Calypso.
Ah, the ship. How did he get it?
Amazingly, the source says he leased it from Lowell Guinness for just 1 symbolic franc a year.
1 franc. You're kidding.
Nope.
Yep.
Symbolic, of course, but it meant he got the ship, and then he poured resources into refitting her, turning her into this mobile laboratory, the main base for diving and filming.
And the Calypso became, well, legendary.
Totally iconic. More than just a ship, the source says she was almost like a character in the adventures, instantly recognizable.
Absolutely. And speaking of iconic, his first big book, The Silent World, came out in 1953. Huge success, wasn't it?
Massive. It captured the public imagination globally. And there's a really interesting detail in the source about that book.
Good one.
It says Cousteau actually predicted correctly that porpoises use echolocation, based just on observations they made from the Elie-Monnier.
Really? How?
He noticed they seem to navigate much better than the humans, especially in murky water or at night, and he figured they must be using some kind of sonar. Remember, sonar tech itself was relatively new then, mostly military.
That shows incredible observation skill.
Oh, it really does. And the book's success led straight to the film, also called The Silent World, co-directed with Louis Malle, who later became a famous director in his own right.
And that film was a sensation,
Yeah.
particularly because of the visuals.
Exactly. It was groundbreaking because it brought the underwater world to cinemas in color for the first time for many people.
The impact must have been enormous.
Huge. The source points out it won the Palme d'Or at the Cannes Film Festival in 1956, which was basically unheard of for a documentary. It didn't happen again until 2004 with Michael Moore.
And an Oscar, too.
Yep, Academy Award for Best Documentary in 1957. This really catapulted Cousteau and the whole idea of underwater exploration into the global spotlight.
And he capitalized on that momentum.
He did. In 1957, he became director of the Oceanographic Museum of Monaco. A really prestigious post gave him an institutional base.
And kept innovating.
Oh, yeah. Around the same time, he was involved in developing the diving saucer, the SP-350.
A diving saucer. Sounds like science fiction.
Huh. Yeah, it looked a bit like one. It was a small experimental submersible for 2 people, designed to explore depths beyond scuba range. Just showed he was constantly thinking about new ways to get down there.
But it was television that really made him a household name, right?
Absolutely. If the film made him famous, TV brought him into living rooms week after week. Those collaborations with American TV networks, the undersea world of Jacques Cousteau.
Ran for a whole decade, 66 to 76.
Yeah. And then the Cousteau Odyssey after that, hugely popular series.
And the red beanie became his trademark.
It did. The source actually mentions that was a conscious choice for filming. Gave the shows this recognizable, personalized adventure feel, made him instantly identifiable.
Smart branding, even back then. He also kept writing.
Co-authored books like The Shark, Splendid Savage of the Sea in 1970 with his son Philippe, and the source includes quite a statement from that book about the oceanic white-tip shark.
What did he say?
He called it the most dangerous of all sharks,
Mm-hmm.
which, coming from him, with all his experience, that carried weight.
Definitely. Now, somewhere along the line, his focus seemed to shift. Or expand, maybe.
I think that's right. If you connect the dots,
Huh.
he really transitioned from being mainly an explorer and filmmaker to also being a major voice for ocean conservation.
Using that huge platform he now had.
Exactly. And the source gives a really powerful example of this back in October 1960. There were plans to dump French radioactive waste into the Mediterranean Sea.
Oh, wow. Near too long, wasn't it?
That's right. And Cousteau organized this massive public campaign against it.
And it worked.
It did. Public opinion swung heavily behind the oceanographers. The source notes that protesters, including women and children sitting on the tracks, literally stopped the train carrying the waste drums. It had to be sent back.
That's incredible. Real direct action fueled by public awareness he helped generate.
A very clear example, yeah.
Yeah.
And he was still pushing the boundaries of human presence underwater, too. In the 60s, he was deep into the Con Shelf project.
MTB, what were those?
Continental Shelf Station. These were really ambitious attempts to build underwater habitats, places where oceanauts could live and work on the seabed for weeks at a time.
Like underwater labs people lived in.
Exactly. Exploring the challenges, physiological and psychological, of living under the sea. Just another part of his drive to understand and maybe inhabit that environment. And then in '73, he formalized the conservation work.
How so?
Co-founded the Cousteau Society for the Protection of Ocean Life, along with his sons and Frederick Hyman, gave his advocacy an organizational structure.
But this period also saw immense personal loss for him.
Yes. Tragedy struck in 1979. His son, Philippe, who the source notes was really being groomed as a successor, a key collaborator.
He died.
Yeah, in a crash of his flying boat, a PBY Catalina near Lisbon.
Oh, that's awful.
The source says Cousteau was absolutely devastated, deeply affected. After that, he called on his older son, Jean-Michel, to step in and work more closely with him. You can see how that loss shifted things personally and professionally.
Yeah, that's profound. Now, you mentioned earlier his later life involves some more controversial topics.
Right. While he's celebrated for exploration and conservation, the source does point to some more difficult areas later on. Specifically, it includes a quote from a 1991 UNESCO Courier interview where he talked about human population control.
Okay, what did he say? It sounds sensitive.
It is. The source quotes him saying, "World population must be stabilized. And to do that, we must eliminate 350,000 people per day. This is so horrible to contemplate that we shouldn't even say it." He follows it by saying the general situation is lamentable.
Wow, that's a shocking statement.
It is stark. And just to be very clear for everyone listening, we're presenting this because it's documented in the biographical source material we're using.
Right, we're reporting the content, not endorsing the view. It's part of the complex picture the source paints.
Exactly. It shows a different, perhaps darker aspect of his thinking on global issues later in his life.
The source also mentions he took on advisory roles.
Yeah, in the 90s, he acted as a consultant for the UN and the World Bank. Shows his influence reached into those kinds of international policy circles.
But not everything was smooth sailing, even within the family or his enterprises.
No, the source notes a legal dispute in 1995. It was with his son Jean-Michel over using the Cousteau name for a resort project in the U.S., which Jean-Michel intended as a for-profit venture.
Family and business, always complicated.
Seems so. And then adding to the difficulties of those later years, something happened to his beloved Calypso.
Oh no, don't say it sank.
It did. Well, it was accidentally rammed by a barge and sank in Singapore Harbor in 1996.
Oh, that's heartbreaking after everything.
Yeah, a really sad moment. They did manage to refloat her later, but it felt like the end of an era.
And then Cousteau himself passed away not long after.
That's right. Jacques Cousteau died of a heart attack on June 25, 1997. He was 87, buried in his family vault in Saint-André-de-Cubzac, his birthplace.
The source mentions something about his faith.
It does. It notes that Archbishop Jean-Marie Lustiger, in his funeral homily, described Cousteau as a man of prayer, and it includes a quote attributed to Cousteau from a posthumous work.
What's the quote?
"The glory of nature provides evidence that God exists." So another dimension to the man beyond the science and exploration.
Interesting. And he had strong opinions on other things too, like fishing.
Oh, yeah. The source includes a pretty pointed quote from him about recreational fishing. He basically said, "Fishermen only claim fish don't feel pain to soothe their own consciences."
Quite direct. Never shied away from stating his views.
Doesn't seem like it. And his legacy. It's just vast, isn't it?
It really is. Over 120 TV documentaries, more than 50 books. And the Cousteau Society is still active, with hundreds of thousands of members worldwide.
And the source notes how he saw himself often calling himself just an oceanographic technician, which seems incredibly modest.
Wildly modest. He was so much more.
Exactly. A sophisticated showman, a brilliant teacher, a passionate nature lover. His work just opened up the oceans for millions, billions probably, who never get the chance to dive themselves.
Though his approach wasn't universally loved by academics at the time.
Right, that divulgationism, as the source calls it, popularizing science. Some academics criticized it for maybe oversimplifying things,
Yeah.
but the source argues that style basically became a cornerstone of modern television broadcasting. It fundamentally changed how science gets communicated to the public. For better or worse, he shaped that.
That's a huge impact in itself. Now, the source mentions one more complex legacy item, the killer algae.
Ah, yes, Clerpitoxifolia. It's an invasive seaweed that caused big problems in the Mediterranean. And the source notes that his oceanographic museum in Monaco, and maybe even Cousteau himself, have been linked to its accidental introduction.
Oh, really? Like released from the museum's tanks?
That's the theory discussed in the source, highlighting that even well-intentioned scientific places can have unintended ecological consequences. It's another layer to his story.
Despite these complexities, his influence clearly endures.
No question. You see tributes still, like IWC releasing watches using wood salvaged from the Calypso. And his grandson, Fabien Cousteau, is carrying the torch with projects like Proteus, this ambitious underwater habitat plan.
The spirit of exploration continues, and the honors he received in his lifetime were significant.
Absolutely. The source lists quite a few. U.S. Presidential Medal of Freedom, Commander of the Legion of Honor in France, a BAFTA Fellowship, elected to the prestigious Académie Française. It shows the immense respect he commanded globally.
So, wrapping this up, what does it all mean? We've gone through this incredible life, from that fateful accident that shifted his path to becoming this global icon, explorer, inventor, filmmaker, conservationist.
Yeah, and I think the key is he didn't just show us the silent world. He kind of gave us the tools, literally, with the aqualung and the inspiration through his films and shows to explore it ourselves. And crucially, he instilled this growing sense of urgency, of responsibility to protect it.
His life really tracked this amazing arc of technological change and underwater exploration, but also this dawning awareness of environmental fragility. He was right at the intersection of both.
He really was. And maybe a final thought for you, something to chew on, based on everything we've discussed from the source. Cousteau's journey kind of highlights something important, doesn't it?
What's that?
That really getting to grips with something complex, whether it's the deep sea or any big issue, it seems to need both things. That drive for technical innovation, finding new ways to see and understand, and this passionate commitment to sharing what you find, to advocating for it, even if it gets complicated or controversial. So the question maybe for all of us is, how do we balance that? That desire to explore, to use resources, maybe, with the absolute need to protect the very things that make discovery possible in the first place.